Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn Liz Powell, Medical Editor at MIMS Learning. Today, I'm delighted to welcome our dermatology clinical advisor, Dr Suneeta Kochhar, to the podcast. However, while Suneeta is a GP with an extended role in dermatology, she also has an interest in cardiology. And today, she will be speaking to me about heart disease in women. Hi Suneeta, please can you tell us a bit about yourself?
Hi Dawn, thank you for inviting me today. I work as a GP in East Sussex and I'm also the clinical lead for cardiovascular disease prevention and women's health in NHS Sussex.
Okay, so well placed to talk about this subject. Right, so historically there has been this view that heart disease is more of an issue for men than for women. Do you think this is still the case?
I think there is a widespread view that cardiovascular disease affects men more than it does women. I feel there is an increased need of understanding cardiovascular disease in women amongst healthcare professionals and the general public.
Okay, so you're talking about general public there, and usually any healthcare thing directed at women. Most recently, it's been about HRT and the menopause, but if you're talking about a sort of serious life-threatening condition, you're talking about breast cancer. Do you think there needs to be more information aimed at women that talks about the risk of CVD?
I think so, Dawn. So when I refer to cardiovascular disease, that includes strokes, heart attacks, and peripheral vascular disease. And cardiovascular disease is the leading cause of death in women worldwide. And actually, 13 times as many women die of cardiovascular disease than of breast cancer. So cardiovascular disease is responsible for 35% of deaths in women each year, which is more than all cancers combined. I think it's an important fact to realise that young women are more likely to die following a heart attack than young men are.
What impact will these misconceptions have on outcomes for men?
I think it's a combination of both of those factors. So, cardiovascular disease in women is understudied, it's often under-recognised. So, we tend to underdiagnose it, and therefore it tends to be undertreated.
What about research? Because women have been underrepresented in research. Do you think there has had a negative impact on outcomes and more needs to be done to have women in research?
I think so. I think the fact that women continue to be underrepresented in clinical trials is one of the reasons why there's insufficient awareness amongst female patients and, of course, their doctors of sex specific symptoms and presentations of cardiovascular disease.
Okay, I mean, this is a long time ago, but I really remember reading a study that found women and men with feminine traits were less likely to be believed than men. I presume men who are a bit more coming across as a bit more masculine. So that struck me as that was sexism. So do you think sexism plays a role?
Well, I think some heart disease symptoms in women can differ from those in men, which can lead to women sometimes being misdiagnosed or their symptoms being related to anxiety.
So what about modifiable risk factors for heart disease? I mean, I think some risk factors affect women more than men.
Yeah, so there are several major risk factors for cardiovascular disease that affect men and women. So that would include hypertension or high blood pressure, having an unhealthy diet, obesity, physical inactivity, smoking, and high cholesterol. But there are other risk factors that have a greater role in the development of cardiovascular disease in women. For example, women with diabetes are more likely to develop heart disease than men with diabetes. Stress and depression affects women's hearts more than men's, and women who smoke are more likely to develop cardiovascular disease than men who smoke.
Okay, so I think there's some evidence that women are less likely to meet cholesterol targets than men. Do you think this is the case, and why do you think this might happen?
It's a good point, Dawn. So I think women tend to be underdiagnosed with cardiovascular disease, which means they tend to be undertreated to target.
And what about female-specific factors such as pregnancy or menopause?
That's a really important consideration, Dawn. So, transition to the postmenopausal status is associated with a worsening of cardiovascular disease risk profile for women. So, that means that conveys the same risk as being male. So, the effects of the menopause include an increase in body weight, there may be an alteration in fat distribution, and an associated increase in other cardiovascular risk factors such as diabetes. So, with the transition to the menopause, the estrogen level production falls. So, systolic blood pressure tends to increase. We see a more adverse lipid profile where the total cholesterol and low density lipoprotein levels increased by 10 and 14% respectively. So postmenopausal reassessment of lipids may be an important consideration in women where we've seen a borderline premenopausal lipid profile. Another important factor would be to recognize that high blood pressure or hypertension or diabetes during pregnancy can increase a mother's long-term risk of developing hypertension, diabetes, and cardiovascular disease.
I'm Pat Anderson, editor of MIMS Learning, and I'd like a couple of minutes of your time to talk with my colleague Dawn Powell about the MIMS Learning subscription. The annual subscription to MIMS Learning is now even better value for money. The subscription gives you access to all the CPD learning modules on the MIMS Learning site, including interactive text modules, audio modules, podcasts, videos, and more, but that's not the whole story. Question for you, Dawn. What was one recent important development that's useful for GPs?
That would be the addition of MIMS to the MIMS Learning subscription. You can link through to MIMS from MIMS Learning and have access to all the drug and therapy listings, guideline charts, shortages trackers, drug releases and discontinuations, as well as the latest news.
News written by journalists with their finger on the pulse, such as Dawn. The addition of access to MIMS really adds value to the MIMS Learning subscription. The next important development is exclusive CPD, created for subscribers only. For example, we've had insights from our in-person event MIMS Learning Live, which you can only get either by going to the event or through the subscription. We've produced 4 bonus episodes of the podcast and 4 conference reports giving subscribers fantastic insights from our expert speakers, including Dr. Steve Holmes, Professor Mike Kirby, Dr. Olivia Hum, and others.
Yes, and even though we do say this ourselves, as an editorial team, we can grasp what really matters to GPs and present that as conference reporting. But is there anything else coming up, Pat?
Yes, I'm glad you asked that, because yes, there is. We've got some new CPD formats giving you essential information in new ways. Our deputy editor, Rhiannon, is developing a pod course, which is 3 linked in-depth podcasts on a particular issue. No spoilers, but the first one is going to be on a topic that reflects everyday general practice involving the complexity and multimorbidity that GPs see every day. And that'll be available to subscribers only in a few weeks' time.
Also in the pipeline, we will be launching a series of flowcharts. These will help you to see how to diagnose, refer and treat key symptoms and conditions at a glance. Importantly, these have been developed with clinicians. They are not something that you could develop with AI. They are something that takes real life human knowledge, expertise and experience. You can view these on our website, print them out, or save them to your desktop for future reference.
Thanks, Dawn. And last but not least, we plan to give you 10 new or updated modules a month for your learning, helping you to meet requirements for your appraisal. So there'll always be plenty of learning to choose from. Looking forward to welcoming you as a MIMS Learning subscriber. Have a look at mimslearning.co.uk/subscribe to find out more.
Okay, so moving on, I think there's this view that myocardial infarction presents differently in women than in men.
Yes, Dawn. So the most common heart attack symptom in both men and women is some type of chest pain, pressure, or discomfort. But chest pain isn't always the most noticeable symptom, especially in women. So women may be more likely to experience it as pressure or tightness in the chest. They may have no chest pain at all. So for women, the pain may be more diffuse, spreading to the shoulders, neck, jaw, arm, and back. Women may experience pain more like heartburn or indigestion, as well as unexplained anxiety or nausea. Heart attacks in women can sometimes be preceded by unexplained fatigue. So when we're comparing men and women, women tend to have symptoms more often when resting and when doing regular activities or even when they're asleep.
What about management? Is that any different for women than it is in men? Is there any female-specific considerations that need to be taken into account?
Studies have shown that young women are more likely to suffer adverse outcomes following a heart attack than young men. Because women's heart attack symptoms can differ from men's, women may be diagnosed less often with heart disease than men. So women having a heart attack delay seeking medical help longer than men because they don't recognize the symptoms. A woman is actually 50% more likely than a man to receive the wrong initial diagnosis for a heart attack. So importantly, the discrepancies in presentation and outcomes between the sexes are often associated with inequalities in the detection, referral, and ongoing management of cardiovascular disease. There's also the predilection for women to develop microvascular angina, and women are 5 times as likely to have normal coronary arteries when compared with men. So women have a lower prevalence of obstructive coronary artery disease, but have a greater symptom burden and functional impairment. So in general, Dawn, cardiovascular disease treatment in men and women is similar, but women are less likely to receive the treatment they need. For example, women are less likely to be treated with antiplatelet therapy and statins to prevent the future risk of heart disease, despite studies showing similar benefits in men and women.
To illustrate how coronary artery disease can affect women and to expand on what Suneeta has been discussing, I'm going to outline a case study. This is from our module on ischemic heart disease by consultant cardiologist Dr Suneeta Kochhar. Okay, so we have Daphne. She's a 72-year-old woman with a 20-year history of type 2 diabetes and hypocholesterolemia. She presented with left-sided chest discomfort, describing it as something that comes and goes. A resting ECG showed normal sinus rhythm with marked left axis deviation. She was treated with aspirin and bispirol. However, she continued to have symptoms despite the medication. Daphne was then referred for a stress echocardiography. Her bispirol was stopped for 48 hours before the test. While the test replicated her symptoms, there was no clear ischemic changes. She was then referred for angiography, and this confirmed significant disease and ischemia in her arteries. Subsequently, she underwent elective bypass surgery. For the full case details, please do take a look at the module. Back to the interview. Suneeta, what are your take-home messages for GPs?
So I think it's really important to highlight lifestyle advice for our patients, and we're all aware of this. So eating a healthy and balanced diet that includes a wide variety of unprocessed and fresh foods, including plenty of fruit and vegetables, whole grains, nuts, and foods that are low in saturated fats, sugars, and salt is important. I think we need to be wary of processed foods, which often contain high levels of salt. I think it's important to highlight to our patients that it only takes 30 minutes of moderate intensity physical activity 5 times a week to improve and maintain health. I think addressing smoking cessation if relevant. It's also important to highlight to our patients to know their numbers. And by that, I mean knowing blood pressure, cholesterol, and blood sugar. So hypertension is the number one risk factor for cardiovascular disease in women. I think it's helpful to promote NHS health checks along with other screening programs for women. I think an awareness of high blood pressure and diabetes during pregnancy can increase a mother's long-term risk of hypertension, diabetes, and cardiovascular disease. So it's important to have a proactive approach in relation to that. And finally, being aware of sex-specific symptoms and differing presentations of cardiovascular disease in women is helpful.
Okay, well, thank you so much for speaking with me today, and thank you to our listeners for joining us. Don't forget, you can claim CPD credits for listening to these podcasts, and there are plenty more on the MIMS Learning website. I've been Dawn Liz Powell, speaking to Dr Suneeta Kochhar, and this episode was produced by Jude Owen. Look out for our next episode, where the MIMS Learning editorial team will bring more highlights from the comprehensive CPD modules we have on our website.